Okay, well, thank you very much. I'm going to 20 minutes, so I don't have a lot of time here, to tell you about what psoriasis is, tell you a bit about what we're doing, some of the challenges we faced, and where I think the future is going to put us as far as stratified medicine is concerned. So you all recognize this person. You all know that during the Second World War, he described Russia as this, a riddle wrapped in a mystery inside an enigma. And I think that the progress we've made with psoriasis over the past 10, 15 years is now starting to change the way we feel about psoriasis. You could have applied that to psoriasis 20 years ago. I think now we have a much greater understanding. The reason I show Winston Churchill is that he was plagued throughout his life by psoriasis. He actually offered a golden statue to someone who would cure him of the disease. It remains unclaimed. And he died of cardiovascular disease, almost certainly as a consequence of him having psoriasis. So there's that systemic element to psoriasis which should not be forgotten. So I'm going to tell you a little bit about P4 Medicine, our SORT program, which is our Stratified Medicine program for psoriasis, and how we're doing this big experiment in Manchester called Manchester Devolved Healthcare, where we might be able to actually approach stratified medicine in a slightly different way. And if you think about health, and I think it's important just to start thinking about the way things are starting to change, is that only about 10% of health is contributed by healthcare. Genetics contributes about 30%, but the big opportunity, of course, is in lifestyle and environment. If we start to think about the way we can really improve the health of our patients and the health of our population, the money should literally be in changing lifestyle and environment, which means that you start to think much more about wellness and health and disease prevention rather than what we currently do, which is disease treatment or disease management. And the reason we can do that, and this is pertinent to stratified medicine, is that there's what are called three megatrends which have now come to the fore which allow us to do this. There's systems medicine, which is looking at the whole organism, and the mathematicians are now heavily involved in modeling these different systems, so you can start to look at an individual in 3 dimensions rather than just genomics or microbiome or immune biomarkers. There's big data analysis, and we've had whole meetings within the Stratified Medicine program talking about big data, but that's a big data, not just the big data we're generating from stratified medicine studies, but big data that comes out on a daily basis from the NHS can now be mined using machine learning to give us information relevant to stratified medicine. And then, of course, there's individual measurement devices and social networks which are contributing information to us from the patients and the general population themselves, which is also very useful when you're looking at stratified medicine, stratified approaches. So in Manchester, we think more about not just stratified medicine, but what's called P4 medicine, which I guess you've heard about before, which is a more holistic way of looking at stratified medicine. So personalizing is what most people think about, which is getting a person on the right drug. There's prevention. Can we prevent someone with psoriasis getting psoriatic arthritis, for instance? Can we predict which patients with psoriasis are going to get cardiovascular disease, or going to get flares, or going to get more severe disease? And then participatory is that the patients themselves, as I've mentioned earlier, are much more involved in their healthcare than they've ever been before. Now, psoriasis, just as a primer for you, is a common disease. About 2 million people in the UK have psoriasis. Most people present with psoriasis before the age of 40, so it's lifelong in most people. There's a link with HLA-CW6 in those patients who develop psoriasis before the age of 40. The very fact that 81 susceptibility loci tells you straight away that this is not one disease. It's many diseases that clinically look very similar. And it has significant comorbidities: psoriatic arthritis, depression, inflammatory bowel disease, cardiovascular disease, and obesity is actually a risk factor for developing psoriasis in people who are genetically predisposed to the disease. And of course, it costs money. That's what this all comes down to. Ill health means the population loses wealth. So on average, patients with psoriasis lose up to 26 days a year because of their disease. And it costs the NHS about £1.5 billion a year. That's how you get grants, otherwise it doesn't look as though it's a very important disease. It always comes down to money. When I studied dermatology 35 years ago, this was the best treatment in town. I mean, it works, and it works extremely well, but patients don't like it. They come into hospital maybe for a month or more at a time, and that's just not feasible nowadays. And of course, it doesn't treat the systemic complications of psoriasis either. But as a consequence of translational research, psoriasis in the early 1980s was recognized to be an immune-mediated condition. Up till then, it was not thought to be the case. And that set in train the sort of whole series of work which has now led to what's called the biologic era for the disease, where we are targeting key components of the immune pathway to improve in a very impressive way psoriasis itself. So nowadays we've moved through anti-TNF, anti-IL-12/23, anti-IL-17, and then the new drugs, the anti-IL-23 specific drugs, produce very significant improvement in about 40% of patients. So some people say, well, psoriasis is sorted out, you don't need to be doing stratified medicine in this disease. And of course, we have a lot of biologics. We have 7, now 8 biologics approved as first-line equivalent therapies for psoriasis patients who fulfill the eligibility criteria. So how do you choose between these? At the present, it's not very straightforward. But those patients who do well do very well. It's been transformational for people with severe disease. They don't have to come into hospital anymore. They can live a normal life, which is a very significant step forward. But the problem is not all patients get this response, and not all patients get this response over the long term. They may get secondary failure, start off doing well, and then the drug starts to fail. So there's a lot of work to be done, not just in the biologic space where we're doing the research, but across all the systemic therapies we use for psoriasis. You all know this. In psoriasis, the case would be, if all of you in this room had psoriasis and I had one biologic therapy to give you, I wouldn't know what you look like, what you're wearing, where you sit in the room, which of you is going to have a good response, who's going to not respond, and who's going to get side effects. We just can't do that at the moment. So it's really much a trial and error approach. We sort of think we know what's the right treatment, but we don't have a really good scientific basis for that. So we want to make it much more targeted to the individual. And actually, that sounds very sort of 21st century. In fact, it's very 2,000 years ago. Hippocrates always got there ahead of us in medicine. If we think we've got it, we've got a breakthrough, he had thought of it first. So his take on stratified medicine is probably the best one. It's far more important to know what person the disease has and what disease the person has. So it's about the individual, and that's that sort of holistic, personalised approach. And the MRC programs in stratified medicine, and when the call came out at the beginning of 2012, was a direct consequence of a decision made by David Cameron and his team that the NHS would be a very good test bed for stratified medicine. And they're absolutely right. You got lots of other things wrong, but actually this is something that he did get right. When I give talks about this in the United States and elsewhere, they are envious of what we can do in the NHS. The way that it is actually collaborative, and it is a fantastic connected system, and we don't use it enough. So why is psoriasis a model disease for stratification? Well, it's common. We use biologics as monotherapy, not like with rheumatoid arthritis where it's used in combination with methotrexate. We can see it. Huge advantage. Therefore, we can quantify very accurately the response to therapy. And also, we can take small biopsies of the skin so we can accurately sample diseased skin which patients find acceptable to them. So that's a big advantage over, say, schizophrenia, for instance. So some people say that the only original piece of thought that went into this program was the name, which is SORT. We're very proud of that, actually. Psoriasis stratification to optimize relevant therapy. So people who are in the know call it SORT. Those who don't know about it, it's P-SORT. The subtlety is that it's not P-psoriasis, it's psoriasis. So what are we trying to do? We're trying to bring clinical, genetic, and immune biomarkers so that we can use those in an algorithmic way to try and predict and reproducibly stratify, in the first instance, response of patients with psoriasis to biologics. Can we use it in a minimally dosed way? Because currently we use biologics in a fixed dose. It's not flexible, it's not personalized. And also, it's got to be cheaper than what we do at the moment, because these are expensive drugs. Can we use them in a more economic, targeted way that actually produces healthcare savings? So obviously, I'm not going to go into great detail, but the health economists are a key component of this program. Absolutely vital. And one of the reasons that we can do this in the UK is because we have a connected dermatological community. Now, Bad Beer is not a poorly performing brewery. It's the British Association of Dermatologists Biologic Interventions Register. And we set this up in 2007. We run it from Manchester. It's a pharmacovigilance register for patients going on to the new biologics, but also as a control on the conventional systemic therapies. In addition to getting very good pharmacovigilance data, we're getting good data, very good data that's relevant to outcome. So where are we at the moment, 11 years on? We've got 160 dermatology centres that we're coordinating around the UK, some in Ireland as well. Got almost 17,000 people in this registry, and 6,000 of those have biological samples, DNA and or sera. So you can see how that is a phenomenal resource. So looking at not just at pharmacovigilance, but looking at stratified medicine. And that's one of the reasons that we got this consortium. And what we're looking at, we're just looking at drug levels, anti-drug antibodies, and adherence, because one of the main reasons people fail drugs is because they don't take them. Even though they tell you they are, they don't. We all know that. And also we're doing some RNA-seq and genomics data, taking biopsies, sequential biopsies from patients starting biologics, biopsies taken at 0, 1 week, and 12 weeks, and looking at RNA signatures in the skin to see if that can also be used as part of other information to predict response. And this is an academic industrial collaboration. That's how these were set up. And without the industrial side, we wouldn't be able to do it. Not just from funding, but from all the expertise that resides in industry, not just the pharma industry, but the diagnostics industry as well. Because we get an algorithm, they're the ones who are going to develop it. Also, we involved a patient group as well, the Psoriasis Association. And the plan is to get people onto the right biologic for them first time round, without that sort of chopping and changing and trial and error. And we talked to the patients at the very beginning as to whether taking a small 2 millimeter punch biopsy, in addition to blood tests and other information, would be acceptable to them. And they said, yes, it would be, if that was going to allow them to get onto the best treatment early in the course of the disease. So these are dynamic programs. Clinical pharmacology I've shown you, immune biomarkers and skin and blood goes through the discovery, refinement, validation. This is where the NIHR becomes important. NIHR are important in the registry, the Bad Beer registry, because it's adopted. Very important to us, very important to smaller centres around the country where they get nursing help to do that. But we've also been able to recruit a large number of patients because this is on NIHR, as we've been able to open other centres and we have nursing help to do this. It's very difficult to get these new patients, get the biopsies, sequential biopsies, but we've got 80 adalimumab and ustekinumab, those are 2 biologic therapies. That's 40 in each group with all those sequential biopsies. And then the refinement cohort, we've got 80, again, in each group. That's 240 patients. It took us 4 years to do that. So we've got an extension to the program by a year to now start to integrate the data. But that was a testament to NIHR being involved and supporting us. It shows what can be done. And also, industry were involved in a much more integrated way. So Signature is a study that was being run by Novartis, an open trial, patients with psoriasis who had failed an anti-TNF, and then we're going to go on to their new anti-IL-17 biologic, secukinumab. And they agreed that all of those patients would have genomics, and a small subset, 50 of them, would have that sequential sampling as well. The NIHR Dermatology Specialty Group were very important in allowing us to set this program up, working with Novartis and getting all the centres to recruit, and they recruited fully to that. And then you start to layer all this information on the multi-omics. This is where it becomes very complicated, but it's not impossible. We've got more data than you could ever imagine, but it's now actually trying to fit it all together and build up that 3-dimensional picture. And what that has also spawned, that's with bad beer and what in the successive sort, has spawned a national network called UK Trend, which is looking now at eczema and atopic eczema and also skin cancer. That again is that collaborative network that's built up and layered on to what we've already been able to achieve with SORT, working with the NIHR. So is this all crazy stuff? Is it just going to way of spending £7 million and keeping some people employed and interested and travelling a bit for a few years, or is it actually going to produce benefit? And I think it probably is. So currently, medical practice is reactive. Patient comes to see me, tells me their symptoms, I find the signs. In the future, it's going to be proactive. We're going to have all that information. We're going to be phoning the patient up and saying, on this information we have on you, we need to see you because you're going to develop psoriatic arthritis, for instance. So this is just quickly some of the data we have. So adherence. Patients on biologics, about 20% of them don't adhere to treatment. They gameplay. They don't use it according to the regimen. If they've gone away on holiday, not taken the drug with them, psoriasis stays clear, they say, okay, maybe I can use it every 4 weeks rather than every 2 weeks. So they don't adhere. So we're trying to ascertain what are the markers for non-adherence so we can predict that and do something about it. You'll be pleased to see this one, yeah? Basically, the drug level is all. If you can, so even with biologics, keeping within a certain range on drug level is important in the blood, but early drug levels in the first month predict long-term response. So if they're not achieving the target drug level in the first month, they're probably going to fail. So that's very useful information. It's not before treatment, but it's very early on. Before we started the study, there was a small study from Italy to show that HLA-CW6, remember I mentioned that at the beginning, can predict, in a sort of way, response to one of the biologics called ustekinumab. A PASI is a severity index for psoriasis. So if they're CW6 positive, 90% chance of getting a PASI 75. If they're negative, drops down to 65%. So we looked at this. One of the first things we did in this study was to use all the data we had from bad beer to see if we could reproduce that, but with a much larger data set. And the answer is yes. That CW6 positive patients have significantly faster and greater chance of getting 90% improvement than if they're negative. In fact, it's the converse. If they are on an anti-TNF, more likely to get a response if they're CW6 negative. So that's useful information. It's not going to be a stratifier, but as part of the picture, it's going to be important. We showed that those patients with early onset psoriasis respond more quickly and better to anti-TNF than those with late onset. So that's another bit of information. And then with the that small biopsies we're taking from the skin, those signatures seem to be the same for if they're going to respond to etanercept or adalimumab, both of which are anti-TNFs, but they have the same signature of response at baseline biopsy. Again, further information that you can get from a small biopsy. And then we can actually just look at the information coming out of bad beer, all that junk of information coming out, which the machine learners can start to make sense of. And so this is Nofa Guy's been using machine learning to look at that bad beer information. She comes up with 4 trajectories of response. Pink line, they're not responding very well. The orange line, they do very well. The green line, they respond to begin with, and then they start to relapse. And you can start to layer onto that information such as genomics, drug levels, and phenotype. And so that's powerful information that you can get just getting the machine learners involved. But also the clinical information tells us something as well. So those patients who are very overweight, who are smokers and have psoriasis on the palms and soles are less likely to achieve a very good response. But what that tells you in part is that lifestyle advice, like losing weight and stopping smoking, may be actually very important in addition to what we're trying to do with getting them on the right drug. And we know that if we screen psoriasis patients in primary care for cardiovascular risk factors, we'll pick up previously unknown or unrecognized cardiovascular risk factors such as high cholesterol, high blood pressure, diabetes, chronic kidney disease. So all of those are important when you start to sort of manage the whole patient. So what we do now is getting them on the right medicine. That's good. That's what we're trying to do. But it's much more than that, because remember I talked about lifestyle and everything else. Because we know that losing weight, stopping smoking, exercising, all on their own improve response to drugs with psoriasis, and actually on their own improve psoriasis. So we're now combining this, get them on the right medicine using that SALT protocol, get them on the right lifestyle using motivational interviewing. So we have psychologists working with these patients about lifestyle coaching. So it's the right drug and it's the right lifestyle. And what we have in Manchester is an opportunity to do that. So 2 years ago, George Osborne's big experiment before he went off to run the Evening Standard was to say, okay, we're going to devolve the health and social care budget for Manchester on an annual basis of £6 billion. Now people say that's probably not enough. But we've got the opportunity where we've got the health and the social care budget together. So we can gain, by investing in health care, to save on social care, which you can't do in many other places in the UK at the present. And that's all based around P4 medicine. So Health Innovation Manchester is bringing together 4 universities, 35 trusts, and industry to see if we can bring P4 medicine into the way we manage our patients across the whole of Manchester, bearing in mind you can invest in health to save on social care. And one of the first experiments we're doing is with psoriasis. This is my last slide. So patients with psoriasis at the moment, they develop psoriasis, go and see the GP. The GP doesn't even look at them. Just says, yeah, you've got psoriasis, have some cream, there's nothing we can do about it. That's it. Doesn't tell them about all the problems they may face with getting psoriasis, how to manage it properly, and people have become disenfranchised. It may take them 12 years or more to come and see a dermatologist. And by that time, all the damage is done. Severe disease, they're depressed, they have the arthritis, the cardiovascular disease, diabetes. It's a problem. So we've set up a clinic now where a patient sees the GP, they've got psoriasis, they see us within 2 weeks. And then we can get them on the right treatment plans, screen them for those risk factors, get them into psoriatic arthritis clinic if necessary. And also some patients we may treat very much earlier on in the disease process with biologic therapies in the hope that we might be able to switch it off. So that, in a way, is sort of the next stage of stratification, because you're getting to see the patients really early and preventing them getting all the side effects. So psoriasis is complex, it's stratifiable, for sure. It's not going to be easy, but it's certainly doable. The SALT data is starting to show some interesting stuff. But it's not on each of those on its own, it's not going to do it. But put together, you may be able to pull up a picture that allows you to stratify that individual. P4 medicine is something that we believe in because it's around prevention as well as getting them on the right drug. And the early intervention may well be true for psoriasis as it is for arthritis, as it is for asthma, and pretty much every other disease. And I started with him, and I'm going to close with Winston Churchill, because another quote that he had was very relevant to what I've just been saying, is that healthy citizens are the greatest asset. So if you can stop people getting the sequelae of these diseases, even if you can't maybe stop them getting the disease in the first place, you're going to be actually helping the population, maybe Greater Manchester, maybe more than that, being wealthier because they're at work and they're contributing. Thank you.